Yeah, we're going to talk about ultrasound of the thyroid. And when it comes to thyroid, there's a bunch of different tests that you can do to work it up, a lot of which include blood tests, and I'm sure you're learning all about that in pathology. But with thyroid ultrasound, it can be useful to differentiate a solid structure in the neck that you palpate from a cystic structure, and also to show maybe solid components within a cystic nodule, and to identify if there's more than one nodule or multinodularity of the thyroid. And also you can see if there's associated lymphadenopathy or lymph nodes, which we talked about in an earlier lesson on ultrasound workup of the patient with a fever. So I won't go into that now. But one of the things about ultrasound that is limiting, though, is that you can't really reliably distinguish benign lesions from malignant ones. Now, there's certain factors I'll talk about that make something look more benign, but really you're going to have to definitively say something is not cancer of the thyroid. You really actually have to do a fine needle aspiration and send it off for cytology or biopsy it. You can also do an isotope scan to see how hot the thyroid nodule is or how active it is. And then there's other imaging tests as well that can look at the thyroid. But ultrasound is generally considered a first-line imaging study of the thyroid because it's inexpensive, it's quite accessible, it's non-invasive, and it's pretty accurate in describing the morphology, how the thyroid looks. And when you compare that to when you examine the thyroid by hand, how inaccurate that can be using the physical exam, ultrasound really does have a leg up here. And you can also see thyroid nodules that you never would have picked up with your hand, smaller ones that were unsuspected on the physical exam. And that's why some really advocate ultrasound for being a screening technique for early thyroid cancer. And keeping that in mind, however, there is a similar thyroid cancer rate in non-palpable and in palpable lesions. So just something to think about. While the rate of thyroid cancer is similar in both non-palpable and palpable nodules, whether patients with screening detected thyroid cancer have better cure rates, quality of life, or survival than patients with clinically detected thyroid cancer, meaning through palpation, remains unclear currently due to lack of research. Now, this is what a normal thyroid looks like. We can see this is the trachea right here, and we can see the right thyroid and the isthmus, and then the left thyroid over here. The corresponding netogram is seen down here with the trachea, the esophagus, in this case posterior, though I often find the esophagus a little bit left of midline. And we can make out this thyroid as it goes all the way across here pretty easily, actually, with ultrasound, because it's so superficial. It really lends itself well to using the high frequency linear probe, which gives us really nice images. And here's an example here of somebody who's got just the anatomy here of the sagittal view coming from the side of the body. We can see the netogram with the arterial and venous supply. It's quite a vascular organ. And we can see here this patient's longitudinal or sagittal view of their thyroid stretches out across our screen when we aim that indicator towards the patient's head. Now, there's when you come across a thyroid nodule, there's a grading system for it. And this grading system has been accepted, and this was published by Fukunari in Pharmacotherapy in 2002. Basically, grade 1, when you put color flow on it, there's no color flow inside the nodule. So grade 1 color grading system actually means no flow at all. Grade 2 is when you have flow only out there in the periphery. Grade 3 is where you've got penetrating flow with moderately rich vascularity. And then grade 4, the most amount of flow, what they call high velocity penetrating flow with a very vascularly rich state. Now, this is an example here of a category 2. I didn't show a category 1 just because it would just look like a regular grayscale thyroid. But this is a a category 2 flow type pattern here with only mapping, color flow mapping out in the peripheral area. And then we get down here to, this is a transverse ultrasound image here of a mostly cystic thyroid nodule with a mural component that did contain flow. The grayscale image initially shows just predominantly cystic nodules seen here with small solid appearing mural component seen here by these arrowheads. But then with color flow Doppler here on the same exact patient shows only flow out there in the periphery. So this when we add the color flow Doppler here, it only shows flow within the mural component shown by these arrowheads here, confirming that this is actually tissue up here and not just debris. Sometimes you see a component that's within this nodule and you think, is it debris or is it actual tissue? Well, debris wouldn't light up this way with color, so we know that this is actual tissue here. And ultrasound guided fine needle aspiration was done where they took a needle into this nodule and into this region here, and basically the lesion was benign at cytologic examination. This next one here is a grade 3 penetrating color flow mapping with a moderately rich vasculature seen here. We can make out the carotid arteries bilaterally here. So this is the left thyroid. It looks pretty normal to me. Here's the isthmus. We come across the right thyroid and it's got this nodule on it, this hypoechoic mass seen over here anterior to the rest of its thyroid. And it shows a moderately rich vascular component consistent with Doppler category 3 type of mapping. And then finally, here's a category 4 high velocity penetrating flow mapping with that's very vascularly rich. And you can see that there's a nodular structure here, maybe even another nodular structure down here, another one, I think I see one up here. And there's a lot of high velocity penetrating flow seen in this particular nodule. This is just a side-by-side image of the same thyroid nodule to demonstrate the role of color Doppler. On the image on the left, you see a grayscale, predominantly solid thyroid nodule. That's what this whole structure is here, the thyroid nodule. The rest of the normal thyroid tissue is down here. And then when we add the color flow, we can see marked internal vascularity. And when you see all this vascularity like this, it really suggests, at least there's a higher likelihood that this nodule is malignant. And this patient indeed turned out to have a papillary carcinoma of their thyroid gland. So when it comes to certain red flags that make us more concerned for cancer, again, you got to do a biopsy to confirm it, but certain red flags, if the patient's male, the extremes of age, if they have a nodule there, if they're less than 20 or greater than 60, if it exudes a rapid growth pattern, if it's greater than 4 centimeters, or it shows signs of local invasion, like the patient has a symptom of hoarseness or they have difficulty swallowing, those kinds of things can make you more concerned about it. So what happens when we biopsy these things? Well, the majority of the time, actually, you get good news back. They're benign, 69% of the time, and you follow them up at 6 to 12 months. And if there's no change, you would probably do nothing. But should there be a morphologic change there, one would consider repeating that biopsy. About 17% of the time, you just don't get enough sufficient tissue back in your fine needle aspiration. And I think that when you do it under ultrasound guidance, that is actually less. You get better results. And so that insufficient value there of 17%, I think that reflects the era prior to doing a lot of ultrasound guided fine needle aspirations. And about 1 in 10 of them appears suspicious on the path report. And these can be follicular neoplasms, of which 85% are benign adenomas. But then it turns out that 5% of the total results here are malignant. And so obviously those are the ones that are going to need to be dealt with. So that's what happens when you do a biopsy. And another thing that comes up a lot with the thyroid is Graves' disease. And you can see that you've got this really hypervascular thyroid nodule here in the setting of Graves' disease. And you can see many times the patient's got the prominent ocular proptosis. We see here a large goiter in the neck. This whole autoimmune situation going on here with these very hyper vascular thyroid nodules seen here, very consistent with Graves' disease when we see that type of pattern, just generally enlarged and hypervascular, just revved up thyroid gland. Now sometimes you see these punctate echogenicities within a thyroid gland, and that's basically a little concerning there for a malignancy. In fact, some would even say highly suggestive of malignancy. This is a sagittal view here of the thyroid, and we can see this part here has got this nodule here has multiple fine echogenicities with the arrows showing here. The arrowheads outline the nodule in this thyroid, and fine needle aspiration and surgery both confirm this was a papillary carcinoma. And here's another example here of punctate echogenicities in the thyroid nodule. Here's a transverse view in this case with the arrowheads outlining the thyroid nodule, and this cystic structure within here. Here's this comet tail. In this case, this comet tail, I should say this echogenic structure here had a comet tail artifact with it, and when you see a comet tail artifact associated with a hyperechoic punctate lesion, you're a little bit more reassured. And these comet tails have to do with the colloid crystals within the thyroid nodule, which are benign. And so I'm going to go back one slide and show you the punctate crystals that don't have the comet tails. In other words, these are hyperechoic bright dots here in the thyroid that they don't have a comet tail that comes down, as opposed to, and I realize as I'm saying this, it's very subtle, but over here, this one does have a comet tail. And so this one turned out to be benign at biopsy. And this is a situation here where we're seeing a sagittal view here of another thyroid mass. This one turned out to be papillary carcinoma. And again, you need to really biopsy these to know for sure. This cystic nodule seen here in this thyroid here went and had a fine needle aspiration. Presumably, it was going to be benign, and indeed, it turned out to be benign on the path report. And so, again, the more cystic these structures are, the more likelihood that these are turn out to be benign. And it says here, fine needle aspiration not performed. Actually, there was one performed, and it turned out to be benign. So that was good. Here's another patient here who's basically got a large goiter, and we're doing an ultrasound in our emergency department on this patient's goiter, and we're seeing a very large multinodular structure here that extends out across the screen. And unfortunately, they didn't use any color on this particular view, but if they did, you would see a really hypervascular organ consistent with a goiter in the setting of Graves' disease. And here's another one here that's got a very large, complex thyroid mass. Some parts are solid, some parts are cystic, and we can see the vasculature there in the neck, carotid, IJ. The carotid is right next to the thyroid. This is the left neck over here, and we can see that's got multiple cystic structures to it. And it turned out that we did a fine needle aspiration on this patient, and it came back benign. Just showing you the way that these complex thyroid masses can present. So that's really all I got for the thyroid. It's pretty quick. What we're going to do with the hands-on session is just examine the thyroid in a transverse view and then in the sagittal view, just to get a good idea on the anatomy, what a normal thyroid looks like.